Dear students, this is lecture number 5 in the topic of inflammation, and this is the last one dealing with the acute inflammation. We will have remaining 2 other lectures dealing with chronic inflammation and bacterial infections of the blood. At the end of this lecture, we should be able to mention the systemic effects of acute inflammation and their causative mediators, and also to explain the different phases of acute inflammation. Today we are going to discuss the systemic effects of acute inflammation or the acute phase reaction. Already we have covered the effects or the response of the inflammation at the site of injury or site of bacterial entry. And we even described many of the inflammatory responses that are localized. However, even if an acute inflammatory response can be, in many of the cases, localized to certain organ or certain tissue, however, it will also have effects on the whole body through sending many of the mediators to the systemic circulation, and this will reach most of the body organs and systems and will create different responses in each one of those. So the main systemic effects of acute inflammation are fever, leukocytosis, elevated level of acute phase proteins, lymphangitis and lymphadenitis, shock, and many other systemic effects. The main chemical mediators that will lead to this systemic response are the tumor necrosis factor alpha, the interleukin-1, and interleukin-6. The first systemic effect of acute inflammation is fever. The word fever means elevation of body temperature by 1 to 4 degrees above the normal range. The mechanism of the fever development include the action or the effect of the bacterial products that are present at the site of the inflammation and bacterial entry. Those bacterial products are called exogenous pyrogens. They are called exogenous because they are coming from outside the body. These products are going to stimulate the leukocytes to secrete other factors that are called endogenous pyrogens. They are called endogenous because they are formed inside the body. These pyrogens, the endogenous ones, include the tumor necrosis factor alpha and interleukin-1, which are basically some of the chemical mediators that we already mentioned before. These pyrogens are going to stimulate the production of prostaglandins. These prostaglandins are key players here in the process. They will travel and they will stimulate the production of neurotransmitters in the hypothalamus and the undersurface of the brain. When this happens in the hypothalamus, we will have a reset of the body temperature to a higher level. And this is why fever develops in acute inflammation. When a patient with acute inflammatory condition consumes non-steroidal anti-inflammatory drugs, they will reduce the fever by blocking the production of prostaglandins. The next systemic effect for acute inflammation is leukocytosis. Leukocytosis means increased leukocytic count up to 15,000 or 20,000 cells per microliter. The normal leukocytic count is not exceeding 10,000 cells per microliter. So if we have this much increase in the total leukocytic count, this will be called leukocytosis. So why leukocytosis happens? It all depends on chemical mediators, again, that are released or produced at the site of the acute inflammatory response, the original site. So of those mediators, we have tumor necrosis factor and interleukin-1. Both of those will lead to release of cells from the bone marrow. The cells here, we mean the white BCs from the bone marrow. In the same time, the colony stimulating factor that is released from the macrophages will also travel through the circulation and reach the bone marrow, and it will increase the bone marrow production of leukocytes. So this is why it's a systemic response, because those mediators are produced at the site of the acute inflammation and they travel through the circulation and exert systemic effects. So what are the different types of cells or white BCs that are increased in different types of infections? So first we have the bacterial infections. It is mainly characterized by increase in neutrophil count or neutrophilia. Then we have viral infections. It is almost always associated with lymphocytosis, increased lymphocytic count. Allergic conditions or parasitic infections are mostly associated with eosinophilia or increased eosinophilic count. Finally, some specific infections like typhoid or rickettsia and protozoal infections are associated with leukopenia. Leukopenia is the opposite of leukocytosis. It means reduction of the white BC's count. And actually, this is a kind of false reduction, because in those specific infections, some cytokines will cause sequestration or trapping of the lymphocytes in the lymph nodes. So it's a kind of a false leukopenia. It's not true. The only thing is that leukocytes are not present in high numbers in the blood, but they are kind of imprisoned inside the lymph nodes. This is why when we take a blood sample, we don't find a lot of leukocytes in those specific infections. So it's a very specific situation. However, the other conditions are more common. So we need to know one last fact about this issue, that when we have a blood sample from a patient, we do complete blood count or complete blood picture, okay? And this complete blood count, we see the total leukocytic count. Then we have something called differential blood count. This differential count will give us the percentage of each and every type of the WBCs. So this is how we know do we have neutrophilia or lymphocytosis or eosinophilia from the differential count, because the total count is a collective count for all the types altogether. The next systemic effect of acute inflammation is elevated plasma level of acute phase proteins. Those proteins are plasma proteins that are synthesized in the liver, and this synthesis is mediated by interleukin 6. So again, this is another role for interleukin 6. The synthesis of these proteins increase in cases of acute inflammation up to 100-folds of the normal rate of synthesis. Those proteins include the C-reactive protein and the serum amyloid associated protein or SAA protein. Both of those proteins act as opsonins, and we spoke about opsonins and opsonization before. This is a process by which those proteins or any other substances coat or bind to the microbial walls to make them labeled and to facilitate their phagocytosis, or even they can facilitate the fixation of complement components on the microbial walls to be targeted by immune cells. The third one of the acute phase proteins is the fibrinogen, and we mentioned fibrinogen before and its vital role in inflammation when it transforms into fibrin, and this fibrin will lead to localization of the inflammation and the inflammatory response, and also it will create scaffold or support system for the leukocytes to migrate in the tissues. In the same time, this fibrinogen will bind to the RBCs in the bloodstream or the erythrocytes. So the erythrocytes will aggregate together if this is their normal appearance or normal presence in the blood flow or bloodstream, here this is the shape of the RBCs when they stick together by the fibrinogen, and this is called the rouleau formation. This rouleau is, if we do centrifuge, will sediment or precipitate rapidly than normal. So this is called the erythrocyte sedimentation rate. This is the basis for this test, erythrocyte sedimentation rate, or ESR. So the erythrocytes, when they are stuck together in a rouleau under the effect of fibrinogen, they will sediment or precipitate more rapidly and increase the erythrocyte sedimentation rate, which is one of the indicators of presence of active inflammation, among other big list of other pathological conditions also. So it is not very specific for acute inflammation, but it is sensitive, which means that in most of the acute inflammatory conditions, we will see elevation of erythrocyte sedimentation rate. The next systemic effect is lymphangitis and lymphadenitis, and we explained both of those terms before. Again, lymphangitis is inflammation of lymph vessels, and lymphadenitis is inflammation of the lymph nodes. So those inflammatory changes are going to happen in the lymph vessels and lymph nodes because of the mediators released. Then we have another effect of the acute inflammation in some conditions, which is shock. Shock can happen because of a severe tissue injury or in cases of severe bacterial infections. So this is not a common condition that happens with everyone or every type of acute inflammation. It happens only in the most severe cases. Why we can see shock in those severe conditions? First of all, shock is a condition that is mostly associated by loss of consciousness and multi-organ effects and multi-organ damage. So this is happening in severe cases because of release of huge amount of cytokines, especially tumor necrosis factors. So there is a cytokine storm in the body, and this will lead to extensive systemic vasodilatation and increase of vascular permeability in the whole body, not only at the site of inflammation. So this is a systemic response that will lead to hypotension and maybe collapse or loss of consciousness. And in the same time, these cytokines, in one way or another, can activate coagulation cascade. So they lead to extensive microthrombi in the whole body circulation, in the small circulation. So this will lead to a condition that is called Disseminated Intravascular Coagulopathy, or DIC. So what is DIC? It is a condition by which we have extensive microthrombi in the microcirculation all over the body because of activation of coagulation cascade under the effect of some reactions related to the large amount of cytokines that are produced in septic conditions that are severe, among also other conditions. So this actually is a life-threatening situation, and it's an emergency, and sometimes it is fatal. Then we have a list of other systemic effects, such as increased heart rate, increased blood pressure, and decreased sweating. And the logic behind that resides in the idea that in inflammation, as we all knew, that there is vasodilatation in the especially superficial tissues. And this vasodilatation, if it continues, it will lead to loss of a lot of heat from the body, because we know that this increased blood flow will lead to hotness, as we agreed before. So because the body will not like this fact, it will try to redirect the blood from the cutaneous tissues to deep tissues to keep it inside, more deep, and prevent the loss of the heat from the body through the skin. It is very important for the body to keep its temperature within the normal range in order to maintain all the physiological and metabolic functions. So this is one of the effects also of acute inflammation. Then we can see also rigors, which mean shivering, and also chills. Chills mean the perception of being cold, even if you're not cold. This is also happening because of the hypothalamic manipulation of the body temperature. There are changes in the hypothalamus and its control on the body temperature. So the patient will feel cold and he will shiver. Also, we can see in cases of acute inflammation, anorexia, which means loss of appetite, drowsiness, and malaise, feeling tired and feeling drowsy. This also will happen under the effect of cytokines on the brain tissue. Now, after all what happened in acute inflammation, the reaction of the vascular changes and cellular events, the inflammatory exudate, the chemical mediators, the types of inflammation, acute suppurative and acute non-suppurative, and then the systemic effects, all of that. After all of this we have completed. Now we are left with one final question. What is the end result of the acute inflammation? What will happen? Is the patient going to survive or die, or he will have damage of his tissues or not? What will happen next after the acute inflammation state? We have 4 possible options as fates for acute inflammation. The first option is complete resolution of the acute inflammation, which means restoration of normal tissue or normalcy. Then we have another fate for the acute inflammatory lesion, which is healing or repair, and we will discuss that in details. We have other options also for acute inflammation fate. Either the acute inflammation can be transformed into chronic and remains in the body, so this will be an option for chronicity, or the acute inflammation will progress and do more damage in the body through spread, and this is called the progression of acute inflammation. So we have 4 main fates for acute inflammation: resolution, healing or repair, chronicity, and progression. So let's start to understand each one of those. First, the resolution. Resolution means that the normal tissue or organ will be completely restored, and there will be no sign of whatever happened in the acute inflammation in that organ. When exactly we can see resolution completely in cases of acute inflammation? First, if the injury is very limited or short-lived, something that is trivial or minor. Also, if there is no or very minimal tissue damage because of that injury. Then the last condition for resolution to happen is that we have injured cells that are able to replace themselves. So even if some cells are dead, we have capacity of the tissue to reproduce and regenerate and create more cells, because this is a feature that is not available in all of our body tissues, as we are going to understand later in the next chapters. So I'll give you a good example for that. For example, if you are holding a flower and the thorn of the flower had injured you, what will happen is you will feel the pain, you will have acute inflammatory response, but most probably within the next day or the day after, you will feel nothing and it will be like there was nothing there. How the acute inflammatory response will be terminated completely? To do that, we need to get rid of all the components or the effects that happened because of the acute inflammation. So first, we need to get rid of the chemical mediators, because the mediators were the main stimuli or signals that started all of this hassle of the acute inflammation. So the chemical mediators need to be neutralized or degraded or destroyed. This is number one. Number two, we need the vessels to be normal again. So we need to restore the vascular permeability. We need the vessels to stop leaking fluids and cells and proteins. We also need the leukocytes to stop their migration, and also they need, even the leukocytes that already migrated, they need to die. So we can start a process of death or suicide, let's say, of leukocytes by apoptosis. So even if we have numbers of leukocytes still in the tissues, they will commit suicide or die by apoptosis, and we will have no more leukocytes recruited to this area. This all will stop. Then the leukocytes, the remaining ones, will start to produce mediators that will inhibit the inflammation. So we will have a counter effect or an opposite effect of the mediators that were already there. We will have another wave of mediators that will stop all the inflammatory reaction. Finally, we will have lymphatic drainage, and the macrophages will ingest all the necrotic debris, all the remaining dead tissues or dead cells. This will lead to clearance of the edema fluid, clearance of the inflammatory cells, and also clearance of the necrotic tissues in the site of the inflammation. So everything will be swept away. The next fate for the acute inflammation is healing or repair. Healing by repair happens in certain situations. So if the resolution fails and there is no option to completely restore the normal structure and function of the organ or the tissue, we have to replace the damaged or the dead tissue by something else. The body cannot stand the presence of damaged tissues or empty spaces in the different organs. So if there is severe tissue destruction beyond the ability of the organ to replace or restore, if the organ or the tissue is formed of cells that cannot regenerate, cannot replicate, cannot make other generations of cells, and they are permanent cells, in this situation, the body will have to replace the dead cells by something else. Also, if the inflammation was formed by large amounts of fibrinous exudates, those large amounts of fibrinous exudates cannot be absorbed in all the cases. So sometimes they will have to be organized and they will have to be managed by the tissues by growing some connective tissue or fibrosis over them. So bottom line, if there is no option to have resolution or a complete restoration of normalcy in the tissues, the body will have to replace the damaged areas by fibrous tissue or by scar in a process called the repair. Again, this will happen in cases of extensive tissue destruction, cases when we have tissues that are unable to regenerate or make more generations of cells, or in cases of extensive fibrinous exudates that are not easily absorbed by the tissues. Now we are left with two other possible fates for acute inflammation. We can see progression of the acute inflammation in the form of spread of infection by direct spread to the neighboring tissues, by lymphatic spread through the lymphatic channels and lymphatic circulation, or by blood spread through the blood vessels to the systemic circulation. This is one of the bad fates because here the body will face a systemic spread of acute inflammation, and this will lead to more pathological effects and more damage to many other organs. Then we have the last fate, which is chronicity or transformation into chronic inflammation. This will happen if the injurious agent is persistent. It is powerful and resistant to the inflammatory response, or there is a kind of recurrence of acute inflammation that is occurring multiple times over a long period of time. So recurrence or persistence of the acute inflammation may lead to a chronic process. And this chronic process will be having two processes going hand in hand together. The chronic inflammatory process together with the healing attempts. So there is inflammation, then the body tries to heal. Then inflammation, then the body is trying to heal it, and so on. So they are going hand in hand together in the conditions of chronicity. So we have these four main fates of acute inflammation, and we can also see them in the next illustrative diagram. So if we start with an injury, like bacteria, infection, like toxin, like a trauma, that can lead to acute inflammation. This will include many events like the vascular changes, the neutrophilic recruitment and activation, and also release of mediators. So this will create the acute inflammation. This can have many options as a fate. One of the options is the complete resolution, which means, as we said, restoration of the normal condition. So this will include clearance of the injurious agent, clearance of the mediators and the acute inflammatory cells, replacement of the injured cells, and restoration of the normal function of the tissues. And everything will go back to normal. Another option for the acute inflammation is healing. And healing occurs by fibrosis or scarring. And this is called repair. This type of healing, as we said before, is depending on the extent of the tissue damage. So if we have extensive tissue necrosis or extensive fibrinous exudates, or in certain types of tissue that cannot regenerate, we will see healing by repair and scarring. And actually, this is not a very good fate because we will have loss of function of this tissue. Suppose that this tissue was a muscle. If you replace a muscle by fibrous tissue, it will not contract like a muscle. So you will have loss of function. Then we have another option of progression. As we agreed, progression can include spread through lymphatics or blood, or even direct spread, or we can see cases of chronicity when the acute inflammation transforms into chronic inflammation and stays for longer duration. And this is another story we will describe in the next lecture. Now let's go to our activity zone to try to revise what we have learned in this lecture. What is the fate? Each one of those sentences is describing one of the fates of acute inflammation. Together, we will read the sentences and find out the most suitable fate in this situation. So, spread by direct lymphatic or blood routes. This is most probably which fate of acute inflammation? Yes, it is progression. So the inflammation is spreading and progressing. The next option, we have persistent or recurrent acute inflammation with the process of inflammation and healing proceeding side by side. So we have acute inflammation that is present for long duration, and the healing attempts continue together with the inflammatory reaction that will also be continuous. This describes which fate of acute inflammation? Chronicity. Yes. Then we have a fate that is caused by tissue destruction and scarring, or it happens if the tissues cannot regenerate. This fate is healing by repair. And finally, if the acute inflammation was followed by restoration of normalcy or normal state, this will be called resolution. So these are again the 4 phases of acute inflammation. Let's go to this activity. We have mentioned in the systemic effect of acute inflammation the step of leukocytosis. And we mentioned that leukocytosis means increase of the total leukocytic count that is seen in the complete blood picture or complete blood count. Then we said that there is another option, which is a differential count. Differential count means that we are going to look at the white BCs as a whole and try to see inside the categories of the white BCs which cells are increasing. So we can see increase of neutrophils, which is called neutrophilia. We can see sometimes increase of lymphocytes, which is called lymphocytosis. And sometimes we can see eosinophilia, which is increased of eosinophils. What are the situations or the conditions that are associated with each one of those? Let's start with neutrophilia. What are the common inflammatory conditions that are associated with neutrophilia? Bacterial infections, yes. Next one, lymphocytosis. Lymphocytosis is mostly associated with which type of infections? The viral infections. Then we have the eosinophilia. Eosinophilia is mostly seen in what type of conditions? We can see eosinophilia in cases of actually 2 conditions: allergy and parasitic infestations. So these are the different types of leukocytosis and their relevance to the their common pathological conditions. So before I leave you, let's take a step backward and have an overview of what we studied till now in inflammation. So inflammation is a protective response of the living tissues to eliminate the harmful injurious agents such as bacteria and also to eliminate the dead tissues or necrotic tissues. And together we agreed that inflammation has 2 main types, acute and chronic. And we listed some differences between both of them in a short list. These differences are mainly the onset. The acute inflammation has rapid onset. Chronic inflammation has gradual onset or start. Then about the duration. The acute inflammation is always of short duration, up to days. But chronic inflammation is a long process that may take up to years. Then also we described a difference regarding the pathological features. We said that in acute inflammation we can see more inflammatory fluid exudates and mainly or predominantly neutrophilic infiltration and also some macrophages. While in chronic inflammation we mainly see cells, and those cells are mainly lymphocytes, plasma cells, and also macrophages. And we see also vessel proliferation. More blood vessels are formed. And this is different some way or another from the acute inflammation. In acute inflammation, the vascular changes include increase in the diameter or in the caliber, increase in the blood flow, and increase in the permeability. While in the chronic inflammation, the main change of the vessel is vascular proliferation, formation of new vessels. Acute inflammation was divided into 2 types, suppurative, which contains pus, and non-suppurative, which has no pus, and it is having many subtypes. What about chronic inflammation? Is it going to have many types or only one single type? And what are the different like inflammatory reactions that happen with chronic inflammation? And what is expected as a fate for chronic inflammation? All of that, inshallah, we will discuss in the next lecture titled Chronic Inflammation. With that, I would like to thank you very much for listening and bearing with me. And inshallah, see you in the next lecture, lecture number 6, in the topic of inflammation.